Hello, I'm Vaughan Keeley. I'm a consultant in lymphedema in Derby, and welcome to this BLS webinar on recognizing cellulitis in people with lymphedema and what to do about it. Cellulitis is a common complication of lymphedema, and patients may experience recurrent episodes. The acute episode itself can be unpleasant and may be severe, requiring hospital admission, can even lead to sepsis and a possible risk of death. On a less severe level, it can result in loss of time from work, etc. It may be a cause of lymphedema, and recurrent episodes can certainly make lymphedema worse. This can be a vicious cycle, as the worsening lymphedema leads to a greater risk of cellulitis. The link with lymphedema, however, is not often well recognized by healthcare professionals, and one of the aims of this talk is to try to increase awareness of the problem. An international study of specialist lymphedema services looking after people with lymphedema and cellulitis showed that 36% of patients had a history of cellulitis. It occurred commonly in both primary and secondary lymphedema, and importantly affected children as well as adults. It was more common in obese patients, more common in those who had cancer-related lymphedema, and more common in those who had diabetes. What is cellulitis? It's a bacterial infection of the skin and the subcutaneous tissues. And in lymphedema, we believe the main pathogens are probably beta hemolytic streptococci. In other types of cellulitis, staphylococci are often blamed, but that doesn't seem to be the issue in lymphedema, although the evidence for this is not strong. The clinical features of cellulitis, again in lymphedema, may differ from other settings. Quite often patients develop flu-like symptoms and fever, often of a rapid onset, which may occur even before they notice anything wrong with their affected swollen limb. There can be pain, redness, a rash, increased swelling, warmth, tenderness, and skin changes with possible blistering and ulceration in the area of lymphedema as the cellulitis develops. The pattern varies from person to person, but in many patients with recurrent episodes, they often follow a similar pattern for each episode. The episodes may be triggered by wounds, insect bites, athlete's foot, and similar issues, but sometimes there may be no obvious trigger. This is a photograph of a classical appearance of cellulitis of somebody with lymphedema affecting their thigh. As you can see, there's clear redness there, and there is increased swelling, although that's not necessarily obvious from the photograph. And we've marked the area of redness, which can be quite helpful to see whether treatment is effective. This is another patient with lymphedema of the right arm, and this is again a fairly clear cellulitis affecting the whole arm, but spreading across the chest wall with fairly clearly demarked areas. In this patient, however, she had other types of episodes of cellulitis, which, like this, produced a blotchy rash associated with fever and systemic upset, but not the very confluent picture seen previously. So how can we tell cellulitis from other non-bacterial causes of acute inflammation that can mimic it? Cellulitis is a clinical diagnosis based on the clinical features I've described already. There are no specific tests that are diagnostic, but a white cell count being raised is helpful to raise CRP, and microbiology, taking samples for culture from wounds and blood cultures in people with more severe cellulitis that might require intravenous antibiotics, can be helpful, although frustratingly, they often don't reveal any useful bacterial growth. An important finding in a study carried out about 10 years ago in the UK, looking at people admitted to hospital with cellulitis, found that 33% of them had misdiagnosed other skin conditions which were labeled as cellulitis, but were not in fact cellulitis. So it just emphasizes the importance of an accurate diagnosis to avoid the inappropriate use of antibiotics, but also to recognize conditions which could be treated by other means and improve as a result of that. So when we're looking at possible cellulitis, we need to think about other conditions such as eczema. One of the common things we see is acute lipodermatosclerosis, where people with venous disease, venous hypertension, get an acute rise in venous pressure, leading to an inflamed leg. but quite often both legs are involved in this situation, and bilateral leg cellulitis is very rare. If there is bilateral inflammation, it's likely to be a cause like acute lipodermatosclerosis, which we often see in obese or immobile patients. Most bacterial cellulitis is unilateral. There is another webinar in the BLS series this week on red legs and the differential diagnosis by Becky Elwell, and I would suggest that people interested in this go to that one as well. This is an example of somebody with obesity and lymphedema, but also venous disease. You can see the typical inverted champagne bottle legs and even ulceration in this patient. But as you can see, also there's significant redness, and this is the sort of lipodermatosclerosis which can occur and worsen acutely and be confused with cellulitis. It's clearly bilateral in this person's case. Is cellulitis in lymphedema different from cellulitis from other causes such as wounds? We don't have huge evidence of this, but there is some suggestion that this is indeed the case. So cellulitis can be as a presenting problem. The first episode of cellulitis may be the first sign of lymphatic dysfunction. So we know lymphatic dysfunction predisposes to cellulitis. So some people may present with cellulitis, and that may be a sign that they have underlying lymphatic dysfunction. So these may be patients who present with the first episode of cellulitis, but no obvious wound or no obvious cause for it. And so we need to think about whether they have an underlying lymphatic problem, and then the cellulitis may precipitate lymphedema. Cellulitis can also be secondary to wounds, and it may be that different bacteria, perhaps the streptococci, are not the main cause here. Maybe it's staphylococci that are involved in these situations. So that's something that might explain some of the differences that we see. As I mentioned earlier, systemic symptoms occur very soon in the development of cellulitis in people with lymphedema, but I don't think we have any clear evidence that they occur sooner than in cellulitis of other causes, although this is the impression that we have in lymphedema clinics. Why are people with lymphedema prone to cellulitis? The old ideas were that because the edema was apparently protein rich, then this was a nice medium for bacteria to grow in, but I think those have largely been replaced now as we understand that there's quite a complex change in the local immune response in people with lymphedema because of the damage to normal lymphatic pathways and the passage of white cells and antigen presenting cells and dendritic cells, etc. This is what's likely to cause the reduced local immune response and a vulnerability to cellulitis. But this problem is still likely to be more complicated than this, and some recent studies have shown that streptococci, for example, have been found to bind to particular receptors, the LIVE-1 receptor, which is on the lymphatic endothelial cell membranes, and they seem to bind to this, which may be why streptococci are particularly problematic in cellulitis in lymphedema, but we need to understand more about this. So how do we treat it? What's the best antibiotic to use, and how long should we treat it for? There's really not a huge evidence base for this, and so some years ago in 2005, the National Lymphedema Patient Group, the Lymphedema Support Network, got together a group of experts in the field of lymphedema and asked us if we would try to get together some consensus guidelines on managing cellulitis in lymphedema, because they had experience from their members that patients going to see their GP were often presented with a GP that didn't seem to understand that there was a link between cellulitis and lymphedema and indeed what to do about it. So the LSN, together with the British Lymphology Society, which is the professional group, as you know, pulled together a multidisciplinary group which developed the consensus guidelines on the management of cellulitis and lymphedema, which was first produced in 2005. They've been reviewed annually. We have a review of the update of the literature. I've been lucky enough to chair the group that does this work. For those interested, and I would suggest it'd be really useful to see, the latest guidelines are available on the BLS website or the LSN website, which are both listed on this slide. So the guidelines that have been published most recently in 2022 have been extensively revised. This is more of a new edition than a simple update. And I'd just like to go through some of the features that we've looked at in this. This guidance is mainly intended to support primary healthcare professionals. It makes recommendations about the use of antibiotics for cellulitis in people with lymphedema, but it also advises when to consider admission to hospital or to outpatient intravenous antibiotic services who may be able to treat people with antibiotics without formal admission to hospital. So prompt treatment of cellulitis and lymphedema does reduce the risk of worsening symptoms and the risk of developing sepsis. It also seems to reduce the risk of damage to the lymphatics, which in turn can predispose to further episodes of cellulitis, as I mentioned earlier. So clinical assessment that we need to think about when we see somebody with cellulitis with lymphedema, the extent and severity of the rash, marking the edge of the erythema as shown in one of the slides earlier, estimating the level of systemic upset. Is there fever? Is there hypotension? Are there serious signs of sepsis that require hospital admission straight away? A white count and CRP are quite helpful in making the diagnosis or confirming it. To treat it ahead of getting the results of these, of course, but they can help confirm it in retrospect in some of those cases where it's not entirely clear. And then taking swabs for microbiology can be helpful, although, as I mentioned earlier, it can be disappointing in the yield of positive results. So in terms of the antibiotics to use, the currently recommended antibiotic is flucloxacillin, which is the one recommended by the NICE guidance. The dose of this is increasing in recent years, and the current recommendation is 500 milligrams to 1 gram 6 hourly. Our local microbiologists are recommending 1 gram 6 hourly is probably going to be the recommended standard dose for people. Technically, this is an off-label dose. The labeled dose maximum is the 500 milligrams, but this doesn't stop it being used as such. Our recommendation is that the treatment be for 14 days. I'll come back to this. Our advice over this has changed to coincide with NICE. We had previously, from largely based on clinical experience over a number of years, recommended amoxicillin 500 milligrams 8 hourly as an effective treatment for cellulitis and lymphedema. Amoxicillin, as you'll be aware, doesn't have much activity against staphylococci, but is very effective against streptococci and is probably a very reasonable antibiotic. But there isn't evidence at the moment that this is the better antibiotic to use. So we've decided to follow the guidance in NICE. Of course, flucloxacillin will treat streptococci and staphylococci. Why a 14-day course? Again, this is not based on any robust studies, but a lot of experience in lymphedema clinics of patients who have shorter courses, say 5 to 7 days, and then seem to get better, but after 2 or 3 weeks, they get a further recurrence of their cellulitis in the same limb. It's almost as though the infection has not been completely treated. And that's led us to feel that as a minimum, and the standard course should be at least 14 days. So we recommend a 14-day course. If it recurs, the cellulitis recurs or deteriorates soon after completing the 14-day course, some patients may need a longer course of antibiotics, but this isn't something to rush into, I think, in primary care. And I would suggest seeking advice from either local microbiology services or specialist lymphedema services about these patients, if you have a specialist lymphedema service local to you. One of the other features that we do recognize is that some of the skin changes, particularly after severe episode of cellulitis, can last for weeks or even months, and these are the aftermath of the cellulitis. If the patient is otherwise well and they've got some staining in the leg, for example, there's no need to carry on the antibiotics longer. This will recover on its own or sometimes persist for a very long time. So if the patient's allergic to penicillin, clarithromycin is our recommended alternative, but as you'll be aware, many patients are taking statins these days, and that's a problem with clarithromycin, so doxycycline is our recommended alternative. One of the key bits is monitoring patients after starting the antibiotics, and I recognize that people can't keep coming back to primary care, but advising the patient to see how they are after 48 hours. If there's been no response or a poor response, but they haven't got worse, then thinking of changing to a second line antibiotic, which we recommend clindamycin, would be the thing to do. If you start a second line antibiotic, you're almost switching the clock back to zero. So you'd need a 14-day course of this, because this would be the effective antibiotic if the flucloxacillin hasn't worked. However, it's really important to say that this is a sort of arbitrary 48 hours. We must emphasize to patients, if their condition deteriorates before that time or any time when they've been taking antibiotics, we need to look at whether they require intravenous antibiotics, either as an outpatient basis or even admission. Sometimes patients develop vomiting with cellulitis, and obviously that affects the absorption of antibiotics, and this may be the reason why they need intravenous antibiotics. So advising patients that if they get worse within any time frame after they've started antibiotics, they should seek further advice, is what we would recommend. So in summary, thinking about whether people require hospital admission or outpatient antibiotic, intravenous antibiotic therapy, then the first thing is any signs of sepsis will require hospital admission, and that may be the presenting signs that you see when somebody presents initially with their cellulitis. However, any deterioration of either systemic signs or local signs at any stage while people are on oral antibiotics means that we have to think again about whether intravenous antibiotics are required and or admission. And then if people have had first and second line antibiotics and neither of those seems to have worked, obviously one of the things to think about is, was the diagnosis of cellulitis correct? Could it have been one of the other causes of inflammation? Or if there's signs of cellulitis convincing, then it may be that hospital admission or outpatient use of intravenous antibiotics is required. So just to look at some other aspects of acute cellulitis, there's often questions from patients about what should they do with compression. And we generally suggest, largely because compression can be very painful for patients, that they consider removing it if it is painful. However, if it's not painful, we suggest keeping the compression on. There's no essential reason why it should be removed. If it is removed, because there's a danger of losing control of the swelling that's perhaps got worse associated with the cellulitis, then replacing it as soon as possible is what we would also recommend. So they can go back into the compression as soon as it's comfortable for them to do so. There has been some thoughts that the use of compression during an acute episode of cellulitis may improve the outcomes, but there's no research evidence to support this yet. So we recommend a sort of common sense approach of putting it back on as soon as it's comfortable enough to do so. In terms of pain associated with cellulitis, we usually recommend paracetamol as a suitable analgesic. Ibuprofen, other non-steroidals may be an alternative. There has been some old data which suggested that non-steroidals may increase the risk of necrotizing fasciitis in people who have lymphedema and cellulitis associated with it, but there's not been any causative link proven. But if patients want to err on the side of caution, then we would suggest sticking with paracetamol. If people are taking ibuprofen and similar non-steroidals for other reasons, such as arthritis, there's no clear reason why they should stop those if they have cellulitis. How should we manage recurrent cellulitis? This is a really significant problem for us in lymphedema clinics, and it's important to think about the best way forward with this. The first thing to say, I think, there are a lot of things we can do now, some of these backed up by good evidence, that reduce the risk of cellulitis without going to use of drugs, and in particular without antibiotic prophylaxis. So good skin care and use of emollients to maintain the skin barrier to reduce the risk of infection getting in is important. And then, as far as possible, avoiding cuts and scratches and insect bites. And if patients do get cuts and scratches, to use antiseptic creams to try to reduce the risk of infection entering into the subcutaneous tissues. Treating skin conditions such as athlete's foot and other skin problems also will reduce the risk of cellulitis. And some patients who have lymph blisters, lymphangiectasia so-called, which then burst and cause leakage, so-called lymphuria, treating that is important. Normally that requires some form of compression to reduce the leakage. treating that's important because those areas that are leaking can be the site for infection to enter. The other things that I think have emerged in recent years that we know that treating the lymphedema does reduce the risk of cellulitis. So there's been a good study in Australia that shows that use of compression treatment, which reduces the lymph volume, also reduces the risk of cellulitis. And there's even evidence that some of the surgical approaches like liposuction reduce the risk of cellulitis. Because we know that obesity is associated with a higher risk of cellulitis, it seems reasonable to look at weight management in those who have a high risk of cellulitis and have a weight problem. So let's go on to look at the possible role of antibiotic prophylaxis. And there was a Cochrane review in 2017 which looked at this, and the key bit here is in bold. The antibiotic is probably an effective preventative treatment for recurrent cellulitis in those who have recurrent cellulitis in the lower limb. And this is based on the patch studies done in the UK, which particularly looked at penicillin, the phenoxymethyl penicillin versus placebo as a trial for seeing if that reduced the risk of cellulitis in those that had repeated episodes. Not necessarily all of those patients had lymphedema. So how do we look at this in a practical way? We do normally say consider antibiotic prophylaxis if there's been 2 or more episodes of cellulitis in 1 year in somebody with lymphedema. And the consider is underlined because it is important. This isn't an automatic, you have to have antibiotic prophylaxis if you've had 2 episodes in 1 year. This is because of the need to think about other ways of stopping the infections that I've just mentioned, but also so we're not using antibiotics unnecessarily. So some of the things to think about if we're considering antibiotic prophylaxis is, where are all the episodes bacterial cellulitis? Could they have been due to other causes such as the acute venous hypertension, lipodermatosclerosis, inflammatory processes, skin conditions that are not due to infection? If that's the case, then antibiotic prophylaxis is not needed. Were the episodes of bacterial cellulitis incompletely treated? So we see this quite a lot in clinics where people have had a number of courses of 5 to 7 days of antibiotics over a period of months, but it may not have been several separate episodes of cellulitis, but one incompletely treated episode. So we need to think about that as well before embarking on the use of antibiotic prophylaxis. Furthermore, if there has been a clear, easily reversible cause, such as athlete's foot or another skin problem, then simply treating that and seeing if that improves will reduce the risk of further cellulitis, and therefore we don't need to consider antibiotic prophylaxis. There are also the non-drug measures that I mentioned earlier to reduce the risk, and I've described these previously, but I want to mention them again here because it's important to address these in parallel. If we are using antibiotic prophylaxis, we want to try and reduce the risk by other methods so that we can hopefully take people off the prophylaxis. And certainly in our clinical practice, we do this. We may treat people, treat their lymphedema, improve the skin, have the antibiotic prophylaxis for a year or 2, and then discontinue it. So what antibiotics do we use, and how do we manage them? So the standard antibiotic of choice is phenoxymethyl penicillin, 250 milligrams 12 hourly for an adult. There was evidence from the patch studies that those with a high BMI greater than 33 didn't seem to do so well. So we've arbitrarily decided to use a higher dose in that group. So we recommend 500 milligrams 12 hourly, and anecdotally, this does seem to be effective. For those allergic to penicillin, clarithromycin is the recommended antibiotic, and those who have penicillin allergy and take statins, then it's doxycycline that we would recommend. So I just want to say a little bit more about penicillin allergy, because penicillins are such a useful antibiotic in the management of cellulitis and lymphedema because of the issue with streptococci, that it's so important to know if the allergy to penicillin is real. As people be aware, a lot of patients think they have an allergy to penicillin, where sometimes it may be clear from the start they felt a bit sick or something when they took flucloxacillin and it was labeled as an allergy. Others who've had rashes, it's more serious to think about it. Obviously, anybody's had anaphylaxis, and we don't think about going anywhere near them with penicillin. But the resistance pattern for group A streps, they still don't seem to be resistant to penicillin, but they have been reported to be resistant to clindamycin, erythromycin, and tetracycline, all of which I've mentioned previously as antibiotics that could be used to treat cellulitis. So penicillins are really important, and we know, as I've just mentioned, that phenoxymethyl penicillin is effective and safe in prophylaxis against recurrent cellulitis. So if we have the opportunity locally of penicillin allergy testing and desensitization, if needed, then this should be considered in patients where they, particularly those who have recurrent cellulitis, where we need to be thinking about antibiotic prophylaxis. How do we follow people up who are on prophylaxis? It's important to do so, and we don't really want to start prophylaxis and then leave patients on it forever. So what we would recommend is reviewing after 1 year, and if the risk factors have resolved and there have been no episodes of cellulitis, discontinue at that stage. If there has been an episode or the risk factors haven't improved, then continuing for a further year and reviewing the situation at that stage. If having stopped the antibiotics after 1 year or 2 years, there's a further episode of cellulitis, we don't automatically go straight back onto the prophylaxis if there's a clear reason why it's happened, which can be avoided in the future. But some patients do need to go back on prophylaxis. And we sometimes think about whether they should be on it lifelong. Now, I've put lifelong in inverted commas here because I think this should never really be a decision made and then just left and forgotten, because even those who we consider may need it long term, we should be reviewing them on an annual basis, probably ideally in a lymphedema specialist clinic, so that further work can be done to see if the risk factors can be reduced. And if they have been reduced and there's been no episodes of cellulitis, we should try again to reduce and come off the antibiotic prophylaxis. And I've mentioned all the first line prophylaxis. I think when we're looking at second line agents, and these are things like clindamycin and cefalexin and such like, they're much messier drugs to use, and there's risk of C. diff, etc. And we would normally look into this more carefully, looking at any microbiology cultures and things we've got. So we would suggest microbiology advice, or if you have a specialist lymphedema service locally, they should be able to help advise about this. To summarize our concerns about antibiotic prophylaxis, one of the main issues is antibiotic stewardship. This is where we try to avoid the unnecessary use of antibiotics to reduce the risk of development of resistance by relevant bacteria. The other main area is the risk of C. difficile infections. Some of the antibiotics we use, such as clindamycin and cefalexin, are particularly prone to inducing this. And again, we need to take this into consideration before prescribing. The next section I'd like to look at is the use of a course of antibiotics, so-called rescue pack, or an in-case course that people can have at home to take should they develop cellulitis. This is not something that every patient with lymphedema needs, and it's not something that we would usually give to every single person that's had one attack of cellulitis, but in selected individuals, it can be a very useful tool. It does mean that patients can take the antibiotic treatment immediately they get the symptoms. As I mentioned earlier, many patients who get recurrent episodes of cellulitis develop the same symptoms and know very clearly when they're developing an episode. So having a 2-week supply of antibiotics at home, which is what we would recommend in this case, and particularly if people are going away to places where they may not be able to get access to antibiotics or medical advice easily, then having those to take on holiday or wherever is advisable. So if they've got that course, we recommend they start it immediately when they develop familiar symptoms of cellulitis, but seek advice as soon as they can to confirm the diagnosis and check that it's responding to the treatment. Those involved with lymphedema services, particularly those who are on antibiotic prophylaxis already, we like them to let us know if they've had to use their in-case course, because we may need to review the management of their lymphedema or antibiotic prophylaxis. And then finally, just to say a little bit about cellulitis in children. I'm not going to go in this in detail because lymphedema in children is rare, but there is a misconception that children don't get cellulitis. They do. They can get it associated with lymphedema. And in terms of managing them, principles are the same. There are nice guidelines on the treatment of cellulitis in children which should be followed, but they may need assessment in hospital and possible admission if they need intravenous treatment. So in summary, bacterial cellulitis is a common, potentially serious complication of lymphedema and may be recurrent. Prompt diagnosis and treatment with antibiotics is important in obtaining good outcomes. And then non-drug and drug measures, i.e. antibiotic prophylaxis, need to be considered in those with recurrent cellulitis. Thank you very much.
So thank you all for listening to that. We've now got several questions that Vaughan and I, Yolanda, can see on the screen. So if you're happy, we'll work our way through those for the next 20 minutes or so. So we're just going to work our way up because the first few questions are about practical sort of actually accessing the session today. So the first question would be from Mukbar Ziad, who's asked, how can we recognise redness and rashes to people with dark skin having cellulitis?
Yeah, I think it can be a challenge at times, something I think we're becoming increasingly aware of. I think there are other features of the condition when it happens, the pain and swelling, but also systemic upset flu-like symptoms, which have been mentioned. But you're absolutely right, it can be more tricky.
Then the next question on the screen is from Margaret Snedden, who's asked, what is your view on routinely providing information on the risk of lymphedema to anyone who experiences cellulitis when no lymphedema is evident?
Okay, so I think it's worth considering. There is good evidence that somebody's first episode of cellulitis may be a sign of them having a lymphatic problem. So if somebody has cellulitis because they've had a wound or an injury and got an infection that way, that's not necessarily the issue. But somebody who presents with cellulitis that has otherwise not had a wound may have an underlying lymphatic problem without actually having overt lymphedema. And this is the sort of situation where we often say the lymphedema has arisen because of the cellulitis. And it may be that they had an underlying lymphatic weakness, if you like, which then predisposed them to the cellulitis and then to the lymphedema. So people in that setting, it's worth them being aware that they may develop swelling, in which case they need to seek advice about it.
Thank you. So the next question is a question about marking the skin. This is from Alexander Curry. And she's asked, when marking with a pen, can any pen be used, or is there specific equipment that should be used?
Gosh, that's, I'm not sure about that. We use the same sort of markers, I think, that we use in the clinic when we're marking the limbs to measure. Katie may be able to add something to that.
Yeah, Andrew, I don't know if you use anything different. We would tend to use the skin pens that we use when measuring limbs. I think in A&E primary care, I don't know whether they have different markers and whether it's more of a felt tip than a skin marker, even in some other settings. But I don't think there's any specific equipment that we keep.
We tend to just use, the only thing is our skin markers that we use are washable, so we tend to, if we're concerned, maybe get something that wasn't going to wipe off. But other than that, the clinic, we would just use the same pens that we use for skin marking for limb volumes or anything else. That's what we have.
I think the difficulty with this is that, as you have seen from some of the slides, some of the patients have more of a rash rather than a discrete area of well demarcated redness. So it's not always easy to mark it. But, yeah.
And then there's another question from Margaret, and she's asked, does application of antiseptic topical preparations have a place in preventing or treating cellulitis and lymphedema?
I don't think we know the answer to that. We usually give advice about treating wounds, cuts and scratches with antiseptic with the hope, as I mentioned earlier, of reducing the risk of infections. But usually one of the key features, as again alluded to in the talk, is that cellulitis can develop very quickly in people with lymphedema and cause systemic symptoms and problems very rapidly. And I think that's not going to be helped by topical preparations, and it may indeed delay having oral antibiotics, which would be the preferred treatment. So I would overall go against that for treating cellulitis, but actually as a potential for keeping a wound clean to reduce the risk.
And so I've had two questions that are similar, one from Catherine, one from Jane. So Jane's asked, do patients need taking out of their compression when they have cellulitis until it resolves? And Catherine's asked, by leaving the sleeve on, will this not push the infection around the body? And that she works in a cancer setting and they treat more cautiously.
So I think this is something that our advice has changed over the years. I think there was a general view that we should take compression off when people had cellulitis and leave it until it resolved. But people began to realize that, excuse me, we lost control of the swelling by so doing, and therefore put patients at greater risk of getting another infection. And generally, we now recommend, as in this guidance, that if patients get a lot of pain with the cellulitis, they should remove the compression. They will tend to do that anyway, quite understandably, because it's too painful to wear. But we try and get it back on as soon as possible, so that we keep control over the infection as much as we, of the lymphedema as much as we can, and therefore reduce the risk of further infections. I think the issue about spreading infection, there is some school of thought that feels that the compression is actually very helpful, and it may be because the compression is improving lymphatic drainage, and it may be helping the flow of the various white cells that are involved in the immune response. That actually improves the response to infection rather than spreading it around. But most of these things are theoretical rather than practical. But it's a bit like the idea about compression and DVTs, that we used to think it was very risky to put compression on when somebody had an acute DVT. When I came into lymphedema, it was a sort of 6-month rule, but it's gradually gone down now until if you've got somebody anticoagulated, you can put the compression on. So the thinking's changed, and there is some evidence for the DVT issue, but that's a bit outside our topic at the moment.
And then I'm not sure if it's more of a comment from Robert about the use of permanent antibiotics, and I guess this would talk about the antibiotic prophylaxis. So he's been having low-grade cellulitis every 2 weeks for about 8 months, and he's now gone on to daily antibiotics and not had a single attack.
Yes, I think this is a difficult one. Sometimes this sort of, Peter Mortimer sometimes uses the term grumbling cellulitis, where it seems to grumble on literally. And there's a lot of debate about whether you have bacteria still embedded, if you like, amongst the lymphedema, which then gets reawoken during an infection. And I think we don't really know the answer to this, but certainly, as I mentioned in the talk, we see people who who keep getting recurrences despite having a good 2-week course. And I think there are cases where we certainly use 6-week course, 8-week course to try and get on top of the infection, and then and this is a treatment course, not just the prophylactic course, to then be able to go back onto a prophylactic dose after that. And my impression, again, there's no good research on this, but my impression that those long courses do break the cycle for a number of patients.
So there's a question from Caroline, who's asked about antibiotics for somebody with lymphedema and cellulitis, and whether patients with lymphedema who experience cellulitis need a different course of antibiotics.
Oh, this is a tricky question. I think the books would tell us people with lymphedema don't get cellulitis, I think, and therefore it's those that have edema as part of their lymphedema. Again, without going too off topic, I think the people that we see with lymphedema that are likely to get cellulitis are those the ones that have edema, and in turn those tend to be people who have a significant weight problem on top of their lymphedema. And so effectively they have lymphedema related to their weight problem, as I see it. And that's what makes them vulnerable to cellulitis. And they should be treated with the same sort of antibiotics that we've discussed here, as it's really to do with their weight-related lymphedema.
So then the next question is from Gemma, who's asked, when suffering with cellulitis, does this put us at higher risk of developing a DVT?
Not that I'm aware of. I'm afraid I don't know any evidence about that, but not that I'm aware of. Obviously, if you're resting up in bed and immobile, then those sort of usual issues about being immobile could put you at risk of cellulitis, of a DVT.
And then Pauline's asked about possible to get a copy of the presentation, and I think there's some work being done to put this presentation as part of the BLS YouTube channel, and so I would imagine that BLS will let you know where to access this in the future. So next we've got a question from Jane, who's asking about that she has a verruca on her foot that has lymphedema, and what would be the best treatment that would avoid a wound, and that the dermatologist refused to freeze it because of having lymphedema, and the over-the-counter treatment hasn't fully resolved and actually worsened the verruca.
This is a really difficult area. I think if anybody's got an answer to this that's 100% reliable, I'd be interested to hear. We've discussed this a lot with dermatology colleagues over the years, and like many, we've tended to steer away from the sort of freezing and curetting and all those sorts of approaches. But some of these verrucas and warts are very resistant. There are the topical preparations which are worth using and can sometimes be helpful. But I think we also have to remember that warts and verrucas sometimes resolve spontaneously on their own, and hopefully that will happen. There are all sorts of things that are being tried. I don't think we've got any great evidence of a wonder treatment for it. We've had anecdotal experience with unusual situations where zinc supplementation, for example, was successful or seemingly successful in one patient, but that's in the literature. But again, I'm not sure that there's enough evidence to recommend that sort of approach for everybody. It's a really difficult area, and I'm not sure that we have a good research-based answer, I'm afraid.
It looks like the next question Yolanda's answered, where it talked about antibiotics for those that are penicillin allergic, and yes, the consensus document and Professor Keeley's presentation talked about alternatives. Then we've answered Catherine's question above that about moving infection around the body.
So there is a sub-question, I think, in one of those about limb elevation during cellulitis and whether that was in treatment. I think that we don't really know the answer to that. I think there certainly patients often have reported that resting does seem to speed up. We have heard anecdotes where people have had grumbling on cellulitis and it hasn't gone away until they've rested as well as having their antibiotics. But it's, again, we don't have any firm evidence that you have to rest. We've also seen other people that carry on doing their normal things and they get better as well. So I don't think we have a definite answer on that.
There's a question there from Karen Boyle asking, can LVA surgery reduce risk of cellulitis?
Does LVA surgery reduce the risk?
Yes, there's some evidence that any sort of surgical treatment that's successful reduces the risk. And I think I mentioned in the talk that there's evidence about liposuction, and also there is some evidence about LVA. Again, as everybody will know, it's sort of in its infancy, and I think my feeling is that all of these approaches, the common theme, if you like, is that you're reducing the swelling and improving the skin, and you're improving the lymphedema. In liposuction, you're unlikely to be improving the lymph flow at all. Well, in fact, you may make it worse, but it still seems to bring about a reduction in cellulitis. So it's early days with things like LVAs to know the best indications for them. But yes, there is evidence that they can reduce the risk of cellulitis.
So Karen's asked a question. A patient that's on long-term penicillin, but in the last year has had recurrent episodes of cellulitis, and I've had 3 this past year.
Yes, I think this is where there's several things here that we sort of go through the process. Is it actually cellulitis that the person is getting each time? Are they unilateral episodes? Does it fit with the proper pattern of cellulitis? Have they had a full course of antibiotics of the 2 weeks? I think these sorts of questions that I was alluding to in the talk are relevant. I think if there are some patients where they seem to be taking their antibiotics okay, the penicillin, and it's still not working, there's the issue to think about their BMI. If their BMI is over 33 and they're only on 250 milligrams twice daily of penicillin, then increasing it to 500 milligrams should be done. We sometimes do this in people whose BMI is less than 33, and that sometimes seems to work as well empirically. I think there are other things to think about there, about what the infections were, where were the infections. If people have got any sort of, say, cellulitis in the groin or thigh or genital area, then the bacteria may be different, and so long-term penicillin is not so effective. In some of our more complicated patients, we have patients that have genital lymphedema as well as lower limb lymphedema, and they can have more than one pattern of cellulitis, and sometimes the lower leg pattern, which seems to be more streptococcal and behave in that sort of way, but the cellulitis that starts in the groin or around the genital area seems to not necessarily behave in that way. Sometimes there can be streptococcal, but on other occasions it's other bacteria, and so we use other antibiotics like trimethoprim as prophylaxis. These are things that are in the full version of the guidance, but because of the length of time we have for the talk today, these are some details that I haven't gone into.
And then there's a question about treatment, and I think it's for treatment while people are having cellulitis. So can we use CDT as treatment and MLD, manual lymphatic drainage, cellulitis when patients are under antibiotics? What if it means for lymphedema when patients are on treatment for cellulitis? Do you think?
Yes, I would imagine, yes. So I think I don't think we have any evidence that the CDT or MLD treats the cellulitis as such, but I recognise that some of the schools of MLD, for example, recommend not doing MLD in somebody with cellulitis. Again, I don't think we have any evidence that is necessarily a problem. The CDT element obviously involves compression, and we've talked about compression and when to remove and replace that. So I don't think there's any hard and fast rules about this.
So then there's a question from Robert asking about highlighting the importance of the management of lymphedema and cellulitis. He's been on medication for 14 months and has kidney function blood tests every 3 months, but nobody has spoken to him about it or examined him.
Yes, I think this is a difficult area. I certainly, and know, speaking to my colleagues who run a similar lymphedema service at St George's, I think we do have a lot of people with really quite difficult to manage cellulitis, and I think as doctors we do get involved in looking at in a lot of detail about what might be the causative organisms, what else might we do, what antibiotics are the right ones to do. Should we be looking at even penicillin desensitization? These are really big, tricky issues, and not necessarily something that a GP or perhaps even a specialist lymphedema service that is run by therapists alone. I think decisions about long-term antibiotics, I think, are really difficult. I certainly find in a number of cases, as I described earlier, we like to get people off the long-term antibiotics as quickly as possible, the prophylactic low dose, I mean. But I think in areas where they don't have as much medical input to their services, I think it is very difficult. sometimes we've seen people who've had have been put on low-dose antibiotics by their GPs, excuse me, but they haven't had follow-up. So we may come across them still on the same low dose some years later. And that's why we're emphasizing in the guidance about antibiotic stewardship, that somehow within the lymphedema services, we need to own this and manage the follow-up of these patients and try to give better support and make decisions about when the antibiotics can be discontinued. But I recognize that not all services are set up in an easy way to do this.
It's a question from Nikki about how can we tell the difference between cellulitis and another skin condition without systemic signs?
Yes, it's. I think Becky's doing a talk. I think it's tomorrow's webinar, if I've got that right, which is about the sort of distinguishing the red legs. But it isn't always easy. But there are some conditions that you can clearly recognise. Ones that we see a lot, I think, are the sort of varicose eczema, acute lipodermatosclerosis on chronic lipodermatosclerosis. The sort of patient I showed a photograph of in the presentation, where it's often somebody with obesity and lymphedema, and they may get both legs being red at the same time without usually any significant systemic upset. And those are the ones where I think they don't have cellulitis. But obviously a whole range of skin conditions, from eczema, psoriasis, all sorts of things can cause redness of the legs or the arms, depending on where the skin condition is. And I think with some of our patients, managing those skin conditions, even if they are getting true cellulitis on top of them because the skin conditions predispose them to the cellulitis, is an important part of it. We're fortunate in our clinic that we have good links, regular input from dermatology, which is helpful to us to manage these things. But and also in the hospital, the dermatologists often end up seeing patients admitted acutely on the wards to advise about whether the condition is cellulitis or another skin problem.
And then there's a question from Sopway Lou about somebody with HIV and recurrent cellulitis, should they have antibiotics for life?
Goodness. I think that's a bit beyond my expertise. I'm not an HIV expert. I think we do have some issues where I can say a bit more. It's not the same issue, but it's patients who are being treated for cancer. I think it may be worth mentioning that. I think talking to HIV experts would be the thing to do here, but from a cancer point of view, if patients are having chemotherapy still for their cancer treatment or starting chemotherapy and are have lymphedema and have had cellulitis, I think our management should be changed because of the chemotherapy. I usually, if we're looking at prophylaxis, it may be a reasonable thing to do, but I have a discussion with the oncologist when we're doing this. And similarly, if people are on chemotherapy, if they're getting neutropenic, our standards and guidelines for managing their cellulitis aren't relevant. They need to be treated under the neutropenic pathway. So I think we have to take these things into account. And I'm not an expert on HIV, but I imagine with that immune suppression, we'll be looking at more intensive management of infection, similar to the patient with chemotherapy for their cancer. So they're likely to need IV. Whether they'll need prophylaxis, I think, is another question.
We've got time for about one more question, I would think, haven't we? So there's a question from Sharon who said, if working in private practice, would a presenting case of cellulitis request for antibiotic to the GP include a link to the BLS, LSN off-label recommendations?
Not sure what that's. So are you, I think the question here is that I'll make some assumptions, maybe that's the thing to do. If somebody presents to a clinic with cellulitis, then if we don't have the ability to prescribe in the clinic, which many clinics, including some of ours, don't have, we would ask the patient to go to their GP and be treated for the cellulitis accordingly. The off-label bit is to do with the 1 gram of flucloxacillin, which is technically an off-label dose, but increasingly it is recommended in NICE. It is something that virtually all hospital guidelines are now moving towards because of the sensitivities of the bacteria to flucloxacillin, so bigger doses are being required. And so I think we're going to see that 1 gram as a sort of standard dose in many guidelines, and we may see more side effects from it as time goes on, because people seem to get more nausea, in my experience, with the higher doses of flucloxacillin.
So I think we've probably reached the end of the hour for the questions. What we can do, and I think was the same as what happened yesterday, is that there was more questions than there is time. And so I think the plan would be that the questions will get stored and we can have a look at them, and possibly look at putting something for news and views, or through the BLS website and emails, if there's any questions that we haven't answered that feel that they're still missing, and we can add those in after the time, if that's okay with everybody.
Good. So I hope you've enjoyed that. It's been some really good questions. Hope I've managed to answer some of them at least. And thank you very much for joining us, and I hope you get some benefit out of the other Lymphedema Awareness Week webinars from the BLS the rest of this week. Thank you. Bye-bye.
Thank you. Thanks very much, Fawn.